Hello, a hearty welcome to all of you to participate in this promising webinar on distinguishing between disorders of gut-brain interaction and cow's milk allergy in clinical practice. I'm Yvan Vandenplas and I will chair this webinar, but the main presentation will be given by Professor Silvia Salvatore from Varese, Italy. This slide shows my conflict of interest, and I'm based in Brussels. I did my medical studies at Free University of Brussels and trained there also in pediatrics. I became head of the unit of pediatric gastro and nutrition in 1987 and became also head of the department of pediatrics, and we created a pediatric hospital called the Kids Health Castle. I had the chair of pediatrics from 94 up to 2021. Actually, I am professor emeritus and consultant at the same hospital. I like to publish, so I have about 600 publications now listed in PubMed, among which many papers on infant nutrition. And at this moment, I'm associate editor of Nutrients. But as said, the main presentation will be given by Professor Salvatore, who is an associate professor of pediatrics at the University of Insubria in Varese, Italy. She is the previous chair of the European and Italian societies of pediatric gastroenterology, hepatology, and nutrition, especially the special interest groups on motility. At this moment, she is also a member of the special interest group of ESGAN on gut microbiota. And she is part of the executive committee of the Italian Society on Pediatric Enteral Nutrition. She has a diploma in pediatric gastroenterology from London, UK, and she did her PhD in our hospital in Brussels, and so she has a PhD in medical science. She has a broad interest. Her specific areas of research include functional and motility disorders, neurogastroenterology, gastroesophageal reflux, esophageal impedance pH monitoring, infant nutrition, cow's milk allergy, celiac disease, inflammatory bowel disease, pre, and symbiotics, and last but not least, she is also interested on the consequences of COVID infection on children. Now, but specifically for this webinar, there is a launch of pre-questions in a poll during the introduction with follow-up questions at the end to understand your knowledge and experience about commies, because the diagnosis of cow's milk allergy is certainly a challenge. And in collaboration with European colleagues, we published earlier this year a new position paper of the European Society of Pediatric Gastroenterology, Hepatology and Nutrition on the diagnosis and management and prevention of cow's milk allergy. Now, one of the major impacts or issues in cow's milk allergy is the diagnosis of non-IgE mediated cow's milk allergy, because there is no other diagnostic tool than oral food challenge, which is refused by many parents, and symptoms are aspecific. So that's why an awareness tool was developed, the COMIS, the cow's milk related symptom score, and this COMIS score was evaluated in our position paper as being quite useful in contributing to the suspicion and diagnosis of cow's milk protein allergy, and not only the score itself, but also its reduction during an elimination diet, which may be indicative for cow's milk allergy. And as you can see on this slide, there was a broad consensus for this statement. But while COMIS might increase awareness and so make healthcare providers more aware about the possibility of a combination of symptoms to be related to cow's milk allergy, it may also favor overdiagnosis. But it might as well decrease overdiagnosis, since in order to have a score which is high enough to suspect cow's milk allergy, you need symptoms in at least 2 different organ systems. And this slide from the UK, published some 8 years ago, shows you that by increasing awareness of healthcare professionals about the possibility of cow's milk allergy as a diagnosis of symptoms in infants, there is indeed an important, the green line, rise in the market share of therapeutic formulas for cow's milk allergy. But on the other side, what you also see, the blue line and the orange line, is that there is a significant decrease of medication which is not needed for the diagnosis of cow's milk allergy, and also a significant decrease of the market share of other formulas. So it does increase awareness if COMIS score, but the increase of awareness is also related to a decrease of selling of drugs which are not recommended and therapeutic formulas not intended for the management of cow's milk allergy. So COMIS score has been quite studied worldwide, and now there are more than 25 publications using COMIS. And just to illustrate, these are 2 recent publications from this year about the evolution of the COMIS-related symptoms in presumed healthy infants following the same group of infants from birth up to the age of 1 year. But also other papers are published here. Another example, cow's milk-related symptom score values in presumed healthy Egyptian infants and European infants in this paper in age between 6 and 12 months. And for Egyptian infants, the paper has just been accepted in Nutrients. So before ending my introduction, I would like to repeat that there will be a line of question and answers from minutes after Silvia's presentation. You can also write your questions in the chat function during the presentations, and these questions will be handled and discussed after the presentation of Silvia. So, Silvia, the floor is all yours now.
Thank you very much for your very nice introduction, Yvan, and welcome to all of you. It's a great pleasure for me to talk to you on disorders of gut-brain interaction that we will call DGBIs and cow's milk allergy, focusing in clinical practice. I'm working at the University of Insubria in Varese, Italy. That are my conflict of interest, and it's the plan for my presentation. I will try to clarify to you what are DGBIs and cow's milk allergy and what's behind, and if we can distinguish them. It's not a new problem, and it's not a new question. Indeed, you can find in JAMA nearly 100 years ago a paper that showed the relationship and the association between DGBIs and food allergy. And going to the future, try to get some help from artificial intelligence. And if you ask to ChatGPT, can we distinguish DGBI from cow's milk allergy, you can guess that the answer is yes. You can distinguish these 2 conditions based on symptoms, underlying mechanism, and diagnostic criteria. And reading further, specifically on dietary history and possible allergy testing and or challenge, elimination diet and then challenge. But is this so easy in clinical practice? I would say no. DGBI, previously called functional GI disorders, are a wide spectrum of clinical manifestation. Some of them are age-related, and specifically in infants, infantile regurgitation and colic, or on the other hand, IBS in adolescents and adults, and some others cross the ages, like functional constipation. We all know about the clinical classification based on Rome 4 criteria. And in infants, the most common DGBI disorders are regurgitation and colic, and less functional diarrhea, dyschexia and constipation, and even rarely rumination and cyclic vomiting. Does it matter in clinical practice? Yes, because 1 out of 4 infants can suffer from these disorders, up to 40% in the first month of life. And for children and adolescents, you can recognize 3 main clinical patterns. One is more related to vomiting, the second is more related to abdominal pain, and the third is bowel dysfunction. And again, 1 out of 8 children that will come to your clinic will suffer from one or even more than one of these disorders. What about cow's milk allergy? Well, the prevalence is a little bit confused because you can find a wide range from 0.5% to 7.5% and even higher. And that's because you can have 2 main manifestations like IgE, positive or related manifestations that are more easily diagnosed, like anaphylaxis or acute reaction, respiratory or GI reaction or skin reaction. And then you have the other part of the spectrum with IgE negative that can also involve respiratory tract, GI tract, skin, and possible growth, anemia, and even blood in the stools in infants. And then there are specific patterns like food protein-induced enterocolitis syndrome, FPIES, or food protein-induced enteropathy, or food protein-induced allergic proctocolitis, and all the other xenophilic disorders that we will not discuss in this presentation. But going back to infants, many infants will suffer from gut dysmotility symptoms or dermatological manifestation or respiratory symptoms. And then if you count all together, you will have with more than 150%. That means that in many infants with cow's milk allergy, you have multiple or combined symptoms. Which kind of symptoms? Well, again, you can have no specific symptoms like vomiting, feeding problems, poor growth, regurgitation, crying, fastiness, and even sleeping problem. But that's are possible symptoms of eosinophilic esophagitis, cow's milk allergy, DGBI, GER and GER disease, but even other conditions. So how can we orientate among them and what's behind? And is it helpful to know the mechanism behind to distinguish them? Well, partially, yes. And if we open in this scenario and the immune background, we will see that cow's milk allergy or food allergy in general will combine IgE involvement or IgG4, some cytokines like IL-4, IL-13, and then antigen-presenting cells, particularly eosinophils, and again, and further mast cells. And these mast cells involvement is important because they can interact with nerves and muscular fiber. And what they create is different conditions like malabsorption, inflammation, dysmotility. What about dysmotility? We already see that depending on the age, we have a different clinical presentation, and that different clinical presentation are caused by IgE-mediated mechanism, mixed mechanism, or non-IgE mediated. And unfortunately, the gastrointestinal and the general symptoms are much more associated with the non-IgE mechanism. In older children and adolescents, you have various mechanisms depending on the type of allergy and individual factor. And they can include histamine release, muscle reaction, increased permeability, altered GI motility, disturbed microbiota, hypersensitivity, and inflammation. What's the problem in clinical practice is that we don't have an ideal test that can combine all these mechanisms and distinguish the clinical situation. And what about the GBI? As well, you have multiple factors that can predispose to them or even cause them. And then even for the infants and older ages, you can point out stress, gut-brain axis dysfunction, or microbiota dysfunction, and food sensitivity and diet. But even for the GBI, currently we have no specific test of biomarkers. And that's create confusion between the GBI or cow's milk allergy, food sensitivity. In some scenario, lactose intolerance is confused with allergy. We have no specific symptoms, no biomarker. Patch test, IgG, basophil, calprotectin are not so accurate, so they are not recommended for this condition. And our food challenge is the gold standard, but is uncommonly performed. And cow's milk protein allergy may predispose to early life inflammation and visual hypersensitivity. And that's clinically important because it's critical to identify at early age the ones who suffers from cow's milk allergy, so we can decrease the chance to have the GBI in the future. So we saw that in clinical presentation, you have multiple symptoms that can be combined in the same patient. And to move from the GBI to cow's milk allergy, you have more than one organ involvement and a clear response to cow's milk free diet or food allergy elimination diet. Whereas if you investigate the patient and you detect more acid reflux, you go through GERD disease, or if you biopsy and you find eosinophilic infiltration, you can classify as eosinophilic disorders. Is constipation related to cow's milk allergy? Possibly yes, and possibly more often at early ages. But the ESPGHAN and NASPGHAN guidelines recommend not to test routinely for cow's milk allergy, the patients who suffer from constipation, but just the ones possibly with intractable constipation don't test, but treat with 2 to 4 week trial of elimination diet. What about patients who can suffer from symptoms of GERD and GERD disease, and which is the prevalence? Again, you can find a wide range between 16 and 56%, and they are more likely in persisting symptoms, possible with both breast milk and formula feeding. Again, most of your patients will not suffer from IgE-mediated, so you don't have a reliable test, and then you try the diet and challenge, and you can have different response and also heterogeneity in the studies. This is one of the best studies that I know. It's recently published by Tyrell Murray, and you can see how many tests he did to try to distinguish an infant who can suffer from GERD disease or cow's milk allergy, and multiple parameters considered. But what he found was that nearly 30% of these infants suffer from non-IgE cow's milk allergy, but you don't have any different baseline parameters or markers. But the elimination diet reduced symptoms, reduced acid exposure and clearance, and improved mucosal impedance. So from Tarero-Murray conclusion, cow's milk elimination and challenge remain the definitive diagnostic procedures. What are the tests? If from your clinical history you go through IgE-mediated form, you can test easily. But again, if you don't have a IgE-mediated form, like for general symptoms and GI disorders, You can test with endoscopy, impedance, but then you have to do elimination diet and challenge. So a little bit disappointment, and how to identify better the children who can benefit from cow's milk elimination diet, and how to avoid an overuse of elimination diet as well. If you have an old child, possibly it's more likely allergy-related symptoms if they are resistant to other treatment, multiple organ manifestation, other atopic conditions, family history of allergy, young age, response to diet, high eosinophils, and lymph node hyperplasia if you do endoscopy or colonoscopy, and possibly other not yet identified. So we are really looking forward this NAPOL score. But in the meantime, can we do something more for infants? For instance, if you have in your clinic Sarah or Yvan, who come because they regurgitate a lot every day for more than 3 weeks, but on the other hand, they're growing well, they're otherwise healthy, you don't have to do anything. You just support the parents and avoid overfeeding, and they will naturally cure it. But if you have a Frances, for instance, she comes because as well she regurgitates, but she also has inconsolable crying. And then she's not like Ivan and Sarah because she vomits since the first week of life. She has failed to thrive and severe eczema. So I guess that possible is cow's milk allergy that cause this kind of symptoms. When cow's milk allergy is more likely? When multiple symptoms are in the same infants. Which kind of symptoms? And based on this concept of multiple manifestation of clinical symptoms in the infant, a group of experts 10 years ago create this cow's milk related symptoms score. And it's based just on 5 easy questions about crying, regurgitation, kind of stools, skin problems, or respiratory symptoms. And if you score them and you get more than 12 at the time, it's more likely that you can benefit from elimination diet. It means that you have at least 3 symptoms, at least 2 organ involvement. But remember, it's just an awareness tool and does not replace a food challenge. The COMIS evolved, and many other tested the COMIS and used the COMIS in clinical practice to try to identify the infants who can benefit from elimination diet. We also tested Marese, and we found that even a lower score like 10, more than 9, would have a very good sensitivity, specificity, positive and negative predictive value. And we published an update our cow's milk related symptom score. So COMIS seems to be a very good and useful awareness tool for cow's milk allergy, and it was confirmed by more than 25 clinical trials and recent guidelines. It's not for cow's milk diagnosis per se, but it can be useful to identify the patients who can have, and also very useful to track the symptoms on diet. It's not indicated for acute IgE symptoms or for enteropathy, food protein-induced enterocolitis or allergic proctolitis or failure to thrive. And this is the most recent guideline from ESPGHAN, which confirmed the accurateness of COMIS as awareness tool. The food challenge remains the gold standard for confirming the diagnosis, but unfortunately, it's not easily performed and many parents refuse it. So COMIS might increase awareness and maybe overdiagnosis, but on the other hand, also decrease overdiagnosis, because to get a positive COMIS, you need at least 2 organ systems involved. So that's the new COMIS. What changes? doesn't change the concept of awareness tool, but we change the stool pattern and the total score. And the total score is now decreased to at least 10 to have a more likely cow's-milk allergy, and less than 6, not likely to have a cow's-milk allergy. That's the difference for the stools. We moved from Bristol, that was designed for adults, to Brussels stool care, more adapted to infants. And then we also proposed a 5 steps clinical to get to identify cow's-milk allergy and to manage this patient. And these 5 steps are based on suspicions of cow's-milk allergy based on your history and physical examination. And then based on that, you decide if it's probably related to IgE or not, and then test between them. Start cow's-milk free diet, if breastfed, maternal diet, if formula fed, hydrolyzed formula, and very rare case elemental formula, then track symptoms on diet, and then plan a reintroduction and the challenge. And you can see then in 2 steps, COMIS can be very useful, both for considering the diagnosis and then to track symptoms on diet. And even for infants can have a persisting regurgitation, vomiting and crying, and if you exclude alarm symptoms and you check that he is not overfed, you can consider the diet intervention for 2-4 weeks. Cow's-milk free diet or thickened formula based on COMIS as well, and track your symptoms, and if they don't improve, you have to test the infants and then reconsider the diagnosis. So at the end, and my conclusion is that we fixed a new cutoff for COMIS as awareness tool for possible cow's-milk allergy, and we fixed at 10. This can distinguish 2 main clinical scenarios, and this score has been validated by more than 25 clinical trials. And we also published this year that if you test COMIS in healthy, normal infants, you can get a median that is completely different, and it's about 3. And then you can use COMIS to track your symptoms on diet and to have a confirmation that the diet is working for your symptoms. The COMIS should decrease after 2, maximum 4 weeks of diet. So the 3 points of my presentation and the conclusion are that DGBI are common in infants and children. The distinction between cow's-milk allergy and DGBI is still challenging, mostly in infants and non-IgE allergy. But COMIS is an easy and useful tool in infants, as when positive, at least 10 as a score, as points, cow's-milk allergy is more likely. Thanks for listening, and it's now time for your comments and questions.
Hello. Thank you, Silvia, for this very insightful presentation. It was very nice. We now have the opportunity for the audience to ask questions, and we do have a lot of questions already which came in. I will start by asking you a combination of 3 different questions. Are postbiotics effective in disorders of gut-brain interaction? And at the same time, what about probiotics? Are they better or less effective? And should you then go for yeast probiotics or bacterial probiotics?
Okay, thank you very much. And thank you for these very important questions. So first of all, we don't have a study proving that a postbiotic can be clinically useful at this time for DGBIs and for cow's-milk allergy, just preliminary results about short-chain fatty acid and possible role of butyrate. On the other hand, it's a fascinating area because postbiotics can modulate inflammation and also possibly modulate pain at the dorsal horn of the spinal cord, so increase or decrease hypersensitivity. About probiotics, we have some evidence that Lactobacillus reuteri DSM 17938 can reduce colic, but just on breastfed infants, and possible bifidobacterium BB12 as well, just evidence in breastfed infants. We have some evidence about Lactobacillus reuteri for abdominal pain in older children, and Lactobacillus GG for IBS in older children, but no other evidence for any other bacterial or yeast in DGBI in infants and children. Just studies on in vitro studies or animal models, but not yet proven strain that significantly improve the symptoms in children.
Okay, thank you. I would be very interested to hear what you think about the next questions. Could disorders of gut-brain interaction be part of the spectrum of non-IG mediated allergies?
Okay, thank you again for this important question. But, well, actually, clinically, the symptoms can overlap. But most of the time, it's an overdiagnosis of cow's milk allergy, in my opinion. And that's also because the response to diet is not a proof that an immune mechanism is involved. Because if you treat an infant, for instance, with the extensive hydrolyzed formula, the formula can improve the gastric emptying. And then if you can make the challenge after a while, you can respond again to the reintroduction of the formula, but not because of an immune mechanism. And sometimes the formula is without lactose, so some patients can improve without lactose for colicky baby. So in some way, yes, but it's not proven that it's immune mediated allergy, and so it's still a challenging situation.
I fully agree. Another very direct personal question: do you personally use COMIS as a screening tool?
Well, not for healthy baby. But I don't think that every infant needs to get COMIS. For infants who have persisting symptoms, that's quite important, because I mean, you don't have to use COMIS for acute symptoms or just symptoms that last 3-4 days or 1 week, because it's possibly related to infection or confused by other situation. But if for persisting symptoms, and I'm biased because I'm doing gastro clinic, persisting gastrointestinal symptoms, I'm a fan of COMIS, so I usually use and try to get some more objective score that it would benefit to change the diet, do an elimination diet. And it's important to use the COMIS in the 2-3 weeks after that. And you have to demonstrate that the COMIS will reduce and then try to get the challenge, try to do the challenge.
Okay, thank you. A question from India linking again functional disorders to cow's milk allergy and brain gut interaction. So the question is, does cow's milk allergy have an impact on the gut-brain axis? What are the neurological symptoms that can be exhibited by the child?
Wow. Uh, so neurological symptoms per se, I don't think that are really linked to cow's milk allergy. But if you consider neurological symptoms, something like irritability or fussiness, or even symptoms related to deprivation of sleep, sleep disturbance that can be caused by cow's milk allergy, we can find a link. But I would stress the point that if you have a neurological impairment, or if you have a milestone impairment, possibly the symptoms are not related to allergy, but are secondary to your neurological impairment. So in clinical practice, I don't think that we really have neurological symptoms of allergy.
Thank you again, fully agree. A question regarding the gastrointestinal microbiota in functional disorders. So in a disorder of gut-brain interaction, if it's suspected, does it make sense to test for dysbiosis?
So I know that it's a hot topic, and it's on fashion as well to have many tested for microbiota. But nowadays, I don't think we have any evidence that you have a perfect standard of your microbiota. And on the other hand, you probably don't need it because you don't know exactly which is the good microbiota. And even if you find dysbiosis, you don't know the control group, and you don't know which is the influence of your diet and possible recent infection or stress or other factor that can cause dysbiosis, and not just allergy or something else. It's proven that if you collect stools from children who suffers from DGBIs, most of the time you have a dysbiosis, but this is cause of consequences, and this is because they use different diet, or this was primary. So I think it's too early. So I will not test for that.
Okay, thank you. We talked a lot about commis. So the question is now, can commis also be used for preterm infants when they are in the intensive care unit?
I don't think we have enough evidence. Could be a good point for research, but in infants, in preterm infants, and in NICU, there are many interfering factors as well that can cause the symptoms, and also some urgent situation that can be confused. And so I'm not sure that could be the perfect tool for this kind of population.
Okay, and do you think that commis can measure the severity of cow's milk allergy?
In terms of clinical presentation, I could say that quantify the symptoms, and so they quantify the intensity or duration of crying, and the severity of skin manifestations. I'm not sure that it can reflect the immune mechanism behind and the severity of inflammation behind, but to make a score and to put a cutoff and to put a level that should decrease on diet, I think it's important to prove that your diet has a sense.
All right.
What's your opinion?
Well, I think yes, since you measured, you quantify the severity of symptoms, somehow there is a relation between the level of commis and the severity of the symptom caused by cow's milk allergy. And what we did show also is that if you put the child on a therapeutic diet, that the commis decreases. So there is certainly a relation. question regarding cow's milk protein allergic proctocolitis, if those infants are at risk for later developing functional gastrointestinal disorders.
There are just a few studies that prospectively assessed this possible evolution. Unfortunately, they are biased by the different method of diagnosis at the beginning and the test afterwards. So we published a review, and if you have early inflammation and intestinal barrier that is damaged, and you create a situation that increase your cytokines or your stimulation of the immune systems and also visual hypersensitivity, you have an increased risk of developing functional GI disorders later on in life, and specifically in pediatric age as well, like functional abdominal pain or IBS. But we still need more prospective data.
Thank you. So a final question. What is the biggest problem, overdiagnosis or underdiagnosis of cow's milk allergy?
I think that I would say overdiagnosis. It's possible, particularly in breastfed infants and in infants who have consider severe crying or agitation. Just that, and comics can help because you have.
Okay,
Silvia, I think that the overdiagnosis decrease.
Thank you, but we lose your connection. So we are anyway at the end of the presentation. So I would like to thank you very much for the very insightful presentation and excellent answers to the many questions. So to all our participants, I would like to say, please complete the feedback form that will be posted in the chat. Please do let us know what other topics you would like to be covered in future COMIS and cow's milk allergy webinars. And of course, you can download the COMIS, the user guide, and the recent podcast on the QR cast to be provided in our final slide that you will see now. And I would like to thank you very much for your participation.
Thank you.